Can you hear me? Okay. I just wanted to first start by saying thank you so much for inviting me to speak here. I'm really honored to be here. So today I'll be speaking about my meta-analysis of blood transfusion and Nadir hematocrit in connection with instances of acute kidney injury and adult cardiac surgery. Oh, hang on 1 second. Let's make sure we actually have my presentation up. Any second now. There we go. Okay. All right. So yes, this is what I will be speaking on. I wanted to do a brief introduction on myself since a lot of my colleagues have respiratory therapy experience, CVOR, they're CVOR RNs. I, however, do not have that background. I did work as an EMT overnights for 6 years while getting my bachelor's in biology with a minor in psychology. I then went on to work as a 911 dispatcher for 6 years, also overnights. So how did I come across perfusion? My husband, Billy, and I had our son, Cooper, 5 years ago. And after swimming in college and being a triathlete, after 3 months delivering him, I found myself hospitalized due to idiopathic postpartum cardiomyopathy. So per my usual curious nature, I relentlessly researched the topic and, of course, of all the worst case scenarios that I could face. While doing so, I discovered the world of perfusion. I'm not sure how anyone could not have, but I, of course, fell in love with it. And over the next few months in the hospital, I became engrossed in consuming all things about perfusion. After getting out of the hospital and after a long recovery, I told my husband I was going to quit my job. I took out my entire pension, and I went to go take some prerequisites. And then I applied to perfusion school, and here I am. I recently accepted a wonderful position, and I will have the opportunity to work with my younger brother, who is a doctor at the same hospital. So I'm very excited. Some of my hobbies are running our little homestead. We love going on family hikes, backpacking trips, rock climbing, snowboarding, and skiing. All right, on to the fun stuff now. So our kidneys, as we know, filter out waste from our blood. They receive almost a quarter of our cardiac output, so our cardiac output is about 5 liters, so the kidneys receive about 1.25 liters of blood through the renal arteries every minute. These structures on your right over there are the nephrons, and those are the functional units of the kidney. We have about 1 million of those in each of our kidneys. Very quickly about glomerular filtration, or the glomerular filtration rate, which is the GFR. That's the amount of blood ever filtered through the kidneys each minute. Our kidneys are very sensitive organs. They're very sensitive to temperature, very sensitive to pressure especially, which is going to go into play as far as cardiopulmonary bypass. So our normal GFR is about 125 milliliters a minute, but it varies with age and other conditions. There's many forces at play when it comes to GFR. First of all, through the afferent arteriole, we have our GBHP, which promotes filtration. And then on the other end of things, we have 2 forces that is a back pressure that opposes filtration, which is the CHP and the BCOP. So if we subtract the CHP and BCOP from the GBHP, we get the net filtration rate, which is about 10 millimeters mercury. So the regulation of renal blood flow is largely controlled by hormones, and they affect mainly arteriolar resistance. 2 main hormones reduce renal blood flow, and that's going to be adrenaline and angiotensin II. Adrenaline or epinephrine is often released during sympathetic stimulation, which patients can often experience, especially with DHCA cases on CBB. Angiotensin II is produced in response to low blood pressure, and it's produced by endothelial cells that line the blood vessels in the entire body, and hypotension is, of course, another common occurrence on bypass. So acute kidney injury and cardiac surgery, since cardiac surgery is a very unique line of surgery. The pathogenesis of AKI is still complex and not fully understood. It's complicated by the difficulties associated with acquisition of real-time kidney data in humans. Renal biopsies are extremely invasive, and so there's no convenient or reliable means of measuring real-time renal blood flow. So on this chart right here, we show that when it comes to cardiac surgery, there's many factors that can cause AKI in patients. First of all, with CBB, we're going to experience hemolysis, which will cause a production of free radicals, which will cause vasoconstriction, leading to reduced renal flow. And there's inflammation and oxidative stress that comes with cardiac surgery, causing inflammatory mediators and complement to be activated, again, causing more vasoconstriction. Other things during CBB, such as low flow, low pressure, non-pulsatile perfusion with hemodilution, there's hypothermia, there's bleeding complications. There are also those neurohormonal factors I spoke about, activation of the sympathetic nervous system, RAS and vasopressin, all leading to vasoconstriction, limiting that renal blood flow. And of course, there's ischemia, reperfusion injury. Also, patients have certain genetic predispositions that can make them more prone to CS-AKI. And then, of course, there's the nephrotoxic agents that are used intraoperatively and postoperatively. So this part I just broke down into 3 time periods that could be factors in cardiac surgery-related AKI, CS-AKI. I broke them into preoperative, intraoperative, and postoperative timeframes. As you can see, there's many factors through the continuum of cardiac surgery that can lead to CS-AKI. So how is AKI measured? There's 3 major criteria used to measure AKI. One of them is the Rifle criteria. And as you can see, they vary ever so slightly. But again, there are 3 different ones. But most of them, though, do measure serum creatinine and then urine output to determine CS-AKI or AKI. So between the Rifle and the Acute criteria, Rifle arranges it in risk, injury, failure, loss, and then end stage, whereas Acute arranges in stage 1, stage 2, stage 3. I personally prefer the KDIGO criteria. The KDIGO criteria attempted to combine both the Acute and the Rifle to create a more cohesive criteria for determining AKI. So why should we study this topic? Since there's very unique characteristics of cardiac surgery, it's definitely something we should consider because AKI complicates recovery from cardiac surgery in up to 30% of patients. 2 to 5 patients require renal replacement therapy, and that's associated with 50% mortality. The development of AKI is associated with prolonged ICU stays, prolonged hospital stays, and that also adds to an increased risk of death for patients. And the patients who develop a new need for hemodialysis, 64% of those will require it permanently, and 90% of those patients will die within 1 year. An overview and objectives of the study was to perform a meta-analysis to evaluate the influence of Nadir Hematocrit on the incidence of AKI in cardiac surgery with patients who are undergoing cardiac surgery with CBB. Secondary analysis was performed to evaluate the influence of perioperative blood transfusions on the incidence of AKI. Information gathered will be used to make suggestions regarding patient care and management during cardiopulmonary bypass. So these were the main databases I used. The methodology was to look through articles pertaining to the topic from 1998 to 2020, and the data was extracted based on my inclusion and exclusion criteria, which I'll go over in a second. To perform a 2-part meta-analysis, part 1 considering the influence of severe hemodilution, Nadir Hematocrit, on the incidences of AKI, and considering the influence of perioperative blood transfusion on the incidence of AKI, trying to find that happy balance between severe hemodilution on pump and trying to prevent AKI, and when to give blood, and also the risks associated with transfusing allogenic blood products. I won't go into this too deeply, but my study selection, basically patients had to be over the age of 18. Both genders were included. They either went through a median sternotomy, heart surgery such as CABG, valve repair, implant of ventricular devices, and then certain patients were excluded, ones who had previous history of chronic kidney disease or end-stage renal disease, because it would be hard to elucidate where the AKI began. My hypothesis was that a restrictive blood transfusion protocol allowing lower Nadir hematocrit during CBB would be associated with more incidences of AKI, and that the administration of packed red blood cells during CBB would be associated with poor long-term patient outcomes and higher rates of morbidity and mortality. So these were my included studies. In the first part, I scoured through articles to find 3 observational studies, 2 retrospective studies, and 1 prospective analysis, and collected data from those in part 1, which I'll have a chart in just a second. In part 2, 5 articles were included that were within the inclusion-exclusion criteria. These were the articles included in my primary review. So from the primary review, the average Nadir hematocrit of the AKI group I found to be lower than the average Nadir hematocrit of the non-AKI group. As I was doing this, I was thinking too, it's easy to see the correlation between these 2 groups. However, it's tough to determine the causation. Also, the group in both parts of the study, the groups that were in the AKI group also had mean aortic cross clamps that were much longer than the other group. So again, there's a correlation. It's hard to determine the causation since longer cross clamp times may mean multiple dosing of cardioplegia, leading to more hemodilution, and therefore causing the AKI. These were the studies involved in my secondary review. I had to break the secondary review up into two separate sections, studies 1, 3, and 5, and studies 2 and 4, because of a difference in the way they reported AKI in relation to transfusion. So in studies 1, 3, and 4, they reported it by mean units of packed red blood cells transfused, whereas in studies 2 and 4, they reported it by number of patients to receive packed red blood cells. But again, we can see in the CS-AKI group, the number of units of blood cells transfused was much higher than the non-AKI group. And then in studies 2 and 4, 86% of people in the CS-AKI group received units of red blood cells, whereas only 31% in the non-AKI group. And this is a chart showing the same thing. And again, I wanted to mention that, again, in the CS-AKI group, they had much longer clamp times than the non-CS-AKI group. So for my discussion, since the perfusionist is responsible for CBB-related management, meaning that education on different mechanisms and possible related causes of CS-AKI can guide the perfusionist to adjust their healthcare practices going forward and try to minimize risk as much as possible. Like I said, sort of a juggling game. Some examples of perfusion interventions that could influence the relationship between CBB and CS-AKI include pump flow, flowing higher, flowing lower. We're not using pulsatile perfusion, which is still a debated topic. Some people believe that it does help kidneys since off-pump cabbages seem to have much less rates of AKI, and they attribute it to pulsatile perfusion. However, research is still out on that. Using higher MAPs, the use of mannitol, loop diuretics like furosemide, the use of ultrafiltration, limiting hemolysis, using miniaturized circuits, and of course the focus on the study is hemodilution when to kind of trigger that red blood cell transfusion. Along with the risk of CS-AKI, allogenic blood transfusion has also been associated with transfusion-related lung injury, hemolytic transfusion reactions, transfusion-associated sepsis, and of course a small possibility still, even with all the testing, of acquiring a viral infection from a donor. The results encourage healthcare providers on the cardiac surgery team to deploy all methods available to them to avoid the need for transfusion of blood products. Some additional techniques that can be used, which at my rotations I've seen, some are more aggressive than others, is salvaging all the blood and washing it after all the volume is left in the CBB circuit to try to get every last red blood cell back to that patient. Taking off autologous units, this is a little bit cost prohibitive, and I've heard that a lot of insurance companies won't cover this, but possibly taking off autologous units with the supplementation of iron and erythropoietin in the time leading up to their cardiac surgery so that the patient can have units of their own blood for retransfusion in the need for blood products. And then even if all those previous methods have been explored, it has also been shown that lower hematocrits can be tolerated in some patients with careful monitoring of signs of proper perfusion. The hemoglobin level that's most transfused between is 7 and 10 grams per deciliter, and the decision to transfuse is usually entirely subjective to the healthcare provider's perception of risk and benefit. So going forward, there's definitely a need for more specific methods for measuring proper tissue oxygen delivery so that patients who can tolerate lower hematocrits aren't receiving unnecessary blood transfusions. There were a few limitations to my study. It was difficult. The reason I have a wide range, 1998 to 2020, I had some difficulty finding specifically articles that addressed Nadir hematocrits and CS-AKI, and then in the second part of the study, there weren't many articles concerning the transfusion packed red blood cells directly in relation to CS-AKI. And then also an important thing to consider is the different ways that right now, AKI is measured. I showed you the Akin, Rifle, and KDIGO criteria. Serum creatinine can vary widely among people, and between men and women. So a very petite woman might have a serum creatinine of 1.4, and that would indicate AKI for her. However, a large male with that same serum creatinine, that is a completely normal serum creatinine for him. So. Again, better criteria hopefully in the future. And of course, in the medical field, technology that's used to monitor patients' conditions and parameters is continually evolving. Better equipment is always being developed to better salvage blood. There's improved pharmaceuticals to prevent bleeding. There's more effective methods to protect renal function. And those can all be factors that contributed to the possible variations between each study since there was a large date range. Thank you so much.